Hello, my name is Priscilla Kofi-Owusu, and I will be talking to you guys about reducing depressive symptoms associated with having obesity. I'll be going over the public health problem, discuss some theories, and then the proposed intervention. The public health problem. According to the Center for Disease Control, 1 in every 10 Americans deal with depression each year, and 70 million Americans are also obese. Various studies have shown that the link between depression and obesity is not just a one-way thing. The two do tend to feed off of one another. It is important to study the two together because not only does the physical state of a person affect their mental health, antidepressive used to treat depression also causes weight gain as a side effect. Obese people are 25% more likely to experience a mental disorder such as depression. Another interesting fact is that obesity and depression are associated with many health risks such as cardiovascular disease, diabetes, and functional limitation. Here we have a chart by the National Center for Health Statistics that was found on the Center of Disease Control website, which explains the correlation between obesity and depression. From the chart, you're able to see that women with depression were more likely to be obese than women without depression. As you can see here, women with depression who were obese is 46.7%, while women without depression who were obese is as low as 33.4%, which is a difference. Adults with depression were more likely to be obese than adults without depression. And also, something that's not shown on this chart but was mentioned was that the relationship between obesity and depression varies by race and ethnicity. The health belief model attempts to explain and predict health behavior by focusing on the attitudes and beliefs of individuals. It was first developed in the 1950s by social psychologists Hochbaum, Rosenstock, and Kegels working in the U.S. Public Health Services. It was developed in response to the failure of a free tuberculosis health screening program. Some of the key constructs for this health belief model are perceived successibility and perceived severity, perceived benefits and perceived barriers, cues to action, and self-efficacy. A study was conducted by Goossens, Barrett, Wigberg, and Mills to investigate the role of anxiety and depression, emotional eating, and its correlation to individuals' loss of control when it comes to body weight. Loss of control is defined as the inability to make conscious limitation of impulses and behavior due to overwhelming emotion. So basically, when a person experiences loss of control, they're constantly eating and they can't stop themselves from doing so. And it's just coming out of impulse. So it's like randomly, like every single time when they're feeling some type of like emotion. So for the study, the sample consisted of 115 treatment-seeking and 73 non-treatment-seeking overweight youngsters ages 8 to 18. Clinical interviews and self-reported questionnaires were implemented to treatment-seeking and non-treatment-seeking individuals. The treatment-seeking group also received support to deal with their anxiety and depression to help lower the loss of control. So some of the support that was given to a treatment-seeking group is they had therapy sessions and just monitoring to make sure that everything was okay. However, from the results, we see that it was reported that the treatment-seeking group actually reported twice as much as loss of control compared to the non-treatment-seeking group. So even though the treatment-seeking group was receiving this extra support, they were still experiencing a lot more loss of control for some reason. Their study also showed that depression did not indeed lead to emotional eating, but was linked the study showed that depression did indeed lead to emotional eating, but was not linked to loss of control. So just because you were depressed didn't mean that you experienced loss of control, but there was a correlation between depression and just emotional eating. Components included self-efficacy and perceived benefits and perceived barriers constructed from the healthy belief model. So self-efficacy was for the teens, between the ages of 8 to 18, their ability to succeed in a specific situation and accomplish a task. So for them to feel that, and perceived benefits and perceived barriers were the way that they thought about getting over the loss of control to help lower their weight gain and battle their depression. The social cognitive theory explains how people acquire and maintain certain behavior patterns while also providing the basis for intervention strategies. Some of the key constructs include environment, situation, behavioral capability, expectations, expectancies, self-control, observational learning, reinforcements, self-efficacy, emotional coping responses, and reciprocal determinism. In another study, social cognitive theory was used to determine how binge eating disorder, weight control, self-efficacy, and depression played a role in overweight men and women. The study consisted of 1,632 overweight individuals, 460 of them being men, while 1,172 were women with the mean age of 50.7 years old. They were recruited from a large Midwestern U.S. managed care organization. Participants were then randomly placed into 3 different categories. One of them was a male-based weight intervention. Then they had a telephone-based weight intervention. And lastly, a usual care group. The treatment consisted of 10 self-paced modules that promoted behavioral goal settings and self-monitoring, decrease in calorie intake, and increase in physical activity. For the results, it showed that the weight self-efficacy showed to be inversely related to weight in both men and women. The women who reported having depression or lower weight self-efficacy at baseline showed to have less weight loss success at the end of the study. So they did 2 check-ins. One was after 6 weeks and the other one was after 12 weeks. And then after that, they were able to see if there was any change at all. And in both situations, the woman who reported having depression experienced no type of change. When it came to men, it showed that depression, binge eating disorder, and weight self-efficacy were not significantly associated with weight loss succession. From both of the studies, I believe that both theories used in the studies did cover some of the most important constructs when it comes to dealing with depressive symptoms and obesity, one of the most constructs being self-efficacy. If you don't believe that you can do something, it's really hard for you to be able to do it at the end. So they did a really good job in trying to get that sense across. However, I do believe that a weakness was that they did, although they mentioned how both obesity and depression tend to feed off of one another, the studies did not mention treatments to combat both obesity and depression in unisex at the same time. So a conclusive intervention needs to be developed that is able to deal with both problems at once. For my proposed intervention, the intervention aims to help men and women of all ages battle depressive behavior that lead to obesity while undergoing a 12-week program. Depressive symptoms are sometimes a barrier to weight loss, and through this mental health-based intervention, participants are able to address and focus on the mind, the body, and the soul. The study would require participants to stay overnight and complete a 2-week program that sets up the foundation of a healthier lifestyle. After the 2 weeks, participants are able to check in once a week for the remaining of the 12-week program. So for the next 10 weeks, they'll come in once a week and just check in to make sure they're still on track. With the use of the cognitive social theory and health belief model, it aims to promote self-efficacy, behavioral capability, reinforcement, and reduce excessive eating and promote the physical activities to stay in shape. Through knowledge about recognizing unhealthy eating patterns, evaluating a participant's environment factor, and providing support through therapy sessions and family and friends encouragement, it ties together to help reduce depressive symptoms and the cause of obesity. For the model, I have my mental health-based intervention, which leads to self-efficacy or behavioral capability, and that depends on the severity of the depression, which is a mediator, and that will lead to the perceived benefits and barriers, which will eventually lead to reduced emotional eating, promotion of exercise, which will reduce depressive symptoms and obesity, or the environmental factors and social economic status would reduce emotional eating and promotion of exercise, because depending on where you are and what access you have will kind of help mitigate exactly what you can actually do to help reduce emotional eating and promotion of exercise, which will eventually reduce depressive symptoms and obesity. Lastly, I believe that therapy and having family and friends to be a support system will also help with reducing emotional eating and promotion of exercise, which will eventually reduce depressive symptoms and obesity. The end.